thank you for everybody for joining us today. As we said, this is the third session of three that we've been doing across the northwest of England. I'm glad that you can attend today. It's been a bit of a series around relationships and issues around integrated care. Perhaps the first session that we had back in December, I think it was about the higher level strategic view about why integrated care was a forwarded idea, how we were developing integrated care boards, what the opportunities were, integrated care systems in particular, and partnerships. And that session went really well with a couple of key speakers. But in the second session, what we did is rather than just do strategy, we went more into specifics of a disease area to give a real life situation for patients, citizens, clients, however you would call them, depending on where you work, and how the integrated care approach would improve the well-being of those people and also their health and well-being life experience. And we did it around cardiological illness, ischemic heart disease, and we got into understanding the wider determinants of a chronic illness like that and how important they are and have a big effect that affects the clinical stroke health related issues. And that became apparent during that talk, as well as talking about the volumes of illness in the northwest with ischemic heart disease. But within that, we recognize that the wider determinants of health are often associated with our partners who are not necessarily from either NHS or health or the care sector, but are around the voluntary sector, the provision that they deliver, and also that our partners in things like housing and the information that they have and the understanding they have about the same people that we manage within the health and care system as well because of their underlying morbidity issues. So today I'm pleased to say that we're going to be moving on to a session and have some really interesting speakers and a panel session, which I'm really looking forward to get a discussion and understanding, a greater depth of understanding, and hopefully questions from yourselves that will illuminate perhaps experiences that you've had or pick into questions or ideas or concepts that our speakers and our panelists can respond to. Okay, so Susie, have we got the agenda on the slide? So here today, I'll just pull this a little bit bigger and I've slapped my glasses on because it's quite small on here. We're going to do in a second a Menti check-in, and we'll use the Menti quite a lot. It's a great tool for online for give you a chance to ask questions and make comments. Even though sometimes we can do it through the hands up on Teams, but this also allows people to come in even if they can't get their hands up or if there are too many questions, but it still allows those questions to be visible. And from that, we will ascertain a lot of feedback from the talkers in the sessions, and we will collect that data so that it's useful for reflection in our overall report for these three Northwest sessions. But without more to do, I think the thing to do rather than hear me talk is we need to move on to some of our guest speakers today. I'm pleased to say the opportunities and collaboration within the housing sector to improve outcomes, reduce health inequalities and deliver long-term improvements. Now that I've met Andrew Van Doorn and understand a little bit more about this, I completely get the key relationships there and how they could improve significantly for the health and well-being of the people that we are here to help. So Andrew Van Doorn is Chief Executive Officer of HACT, that's the Housing Association. And he's going to be talking to us about his views and his perceptions and how it relates to integrated care. So Andrew, welcome. And if I could hand over to you and give us your little presentation, that would be great. Susie.
Just before we do, Andy, there's just a couple of little bits that we need to get through. Sorry, Drew, to kind of just put a slight pause in proceedings. I just want to do a little bit of housekeeping and then just do the Menti, if that's okay.
Oh yeah, sorry, I forgot to do the Menti. I beg your pardon, Susie.
No, that's great. So just the whole session's getting recorded, as I mentioned at the start. So you'll see the little red record button up there. I would ask while speakers are speaking, if you just please put your microphones on mute. But there is going to be a Q&A session at the end of each of the speakers, so you'll have an opportunity to put something in the chat, put your hand up, or we can use the Menti. I'll keep that running just in case people have difficulty with either of those. If you've got a smartphone handy, or if you've got a laptop with two screens and you're able to go onto the Menti shortly, that'd be great. It's you go through www.menti.com and it's code 86921700. I'm going to put a QR code as well, so you can be super fancy and take a picture on your phone if you want to as well. So I'll move on to the Menti bit now. And this is really, I know there's not many of us on the call quite yet. Hopefully more will join us shortly. But I want us to try and populate this as much as possible, because the whole purpose of today's session is not only to hear the fabulousness of the housing sector, the voluntary charity, faith, social enterprise sector, but also to get your views. So as much as you can put onto our Menti is really valuable data for us that we can help to deliver that to decision makers and policymakers. Okay, I'm going to stop presenting that and start presenting the Menti. Smooth as you like. Okay, so there's the Menti. So if we could just all get on there ASAP, and I shall give, oh, look at those people ticking. Love it. Right, okay, great. The 7 8. As many more people as possible can get on there, that'd be great. So it's 86972. Okay, and I'm going to keep on coming on, and I'll move forward for the next question now. Okay, so on your Mentees, could you just let us know what you want to get out of today's session? Just as a quick sentence, a couple of bullet points about what sorts of things you want to get from today. So I can just wait for some responses to come through. I'll keep this screen open during the session as well, but if we can just see a couple of responses coming through, and then I'll let you all off the hook and hand over to Drew. Fabulous, thank you. Thank you for that one response. Oh, here we go, they're coming in now. So yeah, anything you want, because what we'll do as well, we'll tailor some of the breakout sessions to kind of meet some of these needs as well. So as much as you can put in, that'd be great. So we're seeing things around opportunities, collaborations, how to networking, those points of contact, understanding the role you can play within the health and care system as well, and understanding what's working well. So keep them coming. I'll keep it open. I'll stop sharing my screen now, but this will stay open until the next Menti. So thank you so much for this. Now, Drew, apologies for the slight hiccup in that, but over to you now for your fabulousness. Are you able to share your screen, or do you want someone in the team to do that?
No, I'll share my screen. Thanks, Susie.
Thank
and Susie, thanks for inviting me. Hello, everyone. I'm Andrew Van Dorn. People call me Drew. I'm the Chief Executive of HACT, which is the Housing Association's charitable trust. I'm also a non-exec director in the NHS, and I have been for the last 8 years. For about 6.5 years of that, I was a NED in one of London's large acute trusts, and I'm now a non-exec director in a mental health trust in Hertfordshire. So kind of see the world of housing and health from a range of different perspectives. And throughout my career in housing for 30 odd years, I've been basically, I feel that I've been championing this connection between housing and health. I started my career working in homelessness services and direct access provision in particular. And I think anyone who's ever worked with people who experience homelessness kind of know that the main presenting issue, rather than actually people who don't have anywhere to live, is mental health. So for me, very early in my career, I kind of saw a very kind of clear way that housing and the housing and health connection was a critical one. So what I'm going to do is I'm going to kind of talk a bit about where are the opportunities for that kind of collaboration between housing and health, and I will share my screen and hope that it works. Just bear with me. So hopefully you can see that, because now I can't see you necessarily.
Yes, we can see that. Thanks, Drew.
And okay, let me just put that onto slideshow. Great. So let's start with why this matters. So first of all, I mean, this is a figure that has been around for some time now, and the estimation from research is that £1.4 billion a year is a cost to the NHS for poor housing in England. And that £1.4 billion a year is the spent for intervention by the NHS, for clinical intervention. And poor housing describes a range of things, but really it's about what we call the housing in the worst condition. and housing which is either kind of, it's got damp and mold, housing which is in disrepair, housing which actually, if it provides a significant risk to the individual living in the home. So already we know that if we can have better housing, we can improve people's health, and we can reduce the cost to the NHS. And I think what's really interesting about the housing and health kind of connection is that when the NHS was created 75 years ago, the minister responsible, Nye Bevan, was also the Minister for Housing. And he was responsible for a significant for the biggest house building program in this public house building program in this country post-war. So 75 years ago, the connection between housing and health was known, and it was known politically, and it was known as on the ground as well. And over the years, we've kind of lost, I think, some sight of some of that connection. So we know that people who live in poor and unsuitable housing actually have worse health outcomes. We know it is a significant driver of health inequalities, and we know it's one of those significant wider determinants of health. And if you just think about yourself and about your own life, if you can't go home after work, or even where you might be working from home today, and your home feels safe, it feels warm, it feels dry, it's affordable, then actually it has a big impact on your life. It has a big impact on your work. It has a big impact on your friendships and your relationships. It has a big impact on your health. So having those kind of key features of good housing is really important for everyone. And we see the worst, when things really break down, where we see street homelessness and people being unhoused, we see their health deteriorating quite quickly. So if we can work with housing organisations to ensure that people have access to good housing, then we know we get a significant health outcome from that. And we also know that only 20% of our health is derived by clinical intervention, and it's all the other factors that drive good health, such as housing. So the evidence suggests it can improve health and well-being and prevent ill health. And I think the prevention piece is really important for housing, because housing talks about itself in those terms, that we prevent ill health. It means that people can manage their care well, enable people to stay in their homes for as long as they can choose, and also ensure positive care experiences. Again, let's think about where do most of us experience our healthcare? Because it's not in hospitals, it's not in GP surgeries, it's not in healthcare buildings, it's actually in our home. That's where we receive most of our health interventions. That's where we experience our health, and therefore our home is a critical part of that. Yeah, I would also suggest that we pay very little attention often to the conditions of our homes, particularly from a health perspective. There's often a theme that goes on in health, which is it's somebody else's responsibility. It's local government or it's housing organisations. They're responsible for good housing. And actually, I would suggest that we need to make it our responsibility. And integrated care and the environment for integrated care is about us taking joint responsibility across a whole range of different kind of sectors and disciplines to improve the health and well-being of the population. That population health management, population health outcomes are really important. So we also know that, and from evidence, that housing can contribute to some of those stickier issues within our own world in health, around kind of delayed transfers of care, around kind of making sure that people can be discharged at a timely manner from inpatient and hospital provision. But we also know that housing, and when housing is frustrated, for whatever reason, we know that has a significant impact on kind of our recovery, whether that's a physical healthcare recovery or mental health care. So let's just think about, when we talk about housing, it's a bit like people saying health is one thing. Now, you know as well as I do that the NHS is made up of 9,000 organisations. It's made up of lots of different people and professions that do lots of different things. Now, housing isn't as complex as healthcare, but housing isn't one thing. Housing is a range of things, and there's a range of actors and organisations who do a range of different things. And so what's in front of you is roughly the breakdown of kind of what we call tenures of housing in England. So the majority of us are owner occupiers. We live in housing that we own, or that maybe our mortgage company owns, and we're gradually buying it ourselves. The rest of the population live in the rented sector, and it's roughly an equal split. Private rented is slightly higher than social rented. And then there's a new and emerging groups of tenure, which is what we call shared ownership, and mostly that is shared ownership with social landlords. Now, what I want to do now is focus in on the bit of this map, or these housing tenures where there is the biggest opportunity to work in collaboration, and that is the social renter sector. And I'll explain to you why the social renter sector is probably the best group of organisations to work with, and partly it's because they are macro landlords. It's difficult to work with individual owner occupiers because that's the people who own their homes. The private renter sector is made up of 2.5 million micro landlords, and yet the social renter sector is a very large sector of a professional group of organisations providing homes which are more affordable and benefit predominantly those people who experience the worst health inequalities. So let's have a think about social landlords and who they are. So there's 1,400 housing associations in England. Now, the sector, like most sectors, is not equal. There are a small number of very large organisations and a large number of very small organisations. But overall, housing associations provide 2.7 million homes. It's just about 55% of all the social housing, all of the social housing in the country. And that number has been increasing over time as a proportion. So the other group of people who provide social, who are social landlords, provide that to our local government and local authorities. So as I said, a sector made up of a small number of large organisations. The largest social landlord in the country, Clarion, owns 135,000 homes. So they're large organisations working across multiple communities and providing the majority of social housing. The 99% of all social housing is provided by non-profit organisations. And this is really interesting because they're not just not-for-profit organisations with social value at their core, but they're also organisations that don't necessarily see themselves in that wider voluntary community sector kind of domain. What we find in the kind of the housing, in kind of how health connects with the VCSE sector, is that in connecting through VCSE frameworks and networks, they don't really connect with many housing associations. There are some who are engaged in those networks, but not all. And therefore, we need to think slightly differently about how do we engage with social landlords. They are major developers of new housing. They are the main developers and providers of supported housing as well, and they always have been. And governments invested huge amounts of money in these organisations over decades. So they were kind of well-resourced, asset-based, large organisations providing social housing at scale. And as a result, they've got a professional workforce, and a workforce across many different job roles, from people who manage housing to people who do HR and OD, people who do finance, lawyers, people who provide supported housing, care and support staff, people who do grounds maintenance, a whole range of things that people do in kind of maintaining and delivering that housing. They're experienced asset managers. And they're not just experienced asset managers, they're also experienced asset investment managers as well. And I think that's something that marks them out from other sectors. And then finally, they are one of the major providers of individual supporting communities and also for community-based work. And I want to say something about the community-based work, because this is a bit about housing that most people don't really see or understand. So housing associations in England spend £750 million a year in what we call community investment. And community investment is that kind of the language that we use in housing to describe all of the kind of community-based work that we do. So in there is lots of work around health and well-being, lots of programs that are funded and supported, lots of partnerships with VCSE organisations and with NHS organisations in the community to improve people's health and well-being. And unsurprisingly, over the past few years, that focus has been increasing. It's been very much on kind of well-being, around mental health and well-being, those kinds of things as a result of COVID. One of the biggest areas that they invest in is around education, training and employment. So we know that people who live in social housing are more likely to be unemployed than the broader population. So therefore, how we support people to have access to good jobs, jobs that pay well, that have good prospects, move out of kind of precarious employment is a really key issue for social landlords. And we invest a huge amount of money in those kinds of pathways into employment. Do a lot of work around anti-poverty programs, lots of work around kind of financial inclusion and financial debt advice, lots of responding to the cost of living crisis. We've been, for example, working with a network of 200 organisations across the country to get energy vouchers out to people who need it. So dealing with some of kind of the cost of energy. Digital inclusion is a key part of their work, and as well as some of the poverty work around kind of food insecurity. There's a big stream of work around youth empowerment, and many housing associations provide lots of good youth services across the country. There's a lot of community development that goes on in actually working alongside and within communities to help people live there, to kind of come up with their own solutions, and using asset-based community development approaches. And then finally, housing associations are one of the biggest owners of community centres in the country. And they may not manage those centres, that might be done by other organisations, but they actually own the assets. So again, organisations with a breadth of expertise and a breadth of connection in communities, and a connection in those communities that experience the worst health inequalities. So what can we look at around collaboration? I've got a few slides here that's going to look at, where might we look? Well, first of all, preventing people from entering hospital and promoting independence. We see lots of collaborations across the country between housing and health that are doing just this. So kind of helping people to lead a confident life through their health and wellbeing programs. Early intervention work with people with known conditions. There's a really great piece of work going on currently in Walsall, Health Champions, kind of where the housing association is employing local tenants around kind of to really help people access diabetes services, recognizing that's one of the significant issues for the communities in where they work. We got people so it's about helping people to get access to good services, but also helping to make sure that they don't there isn't further deterioration of their health conditions. And there's a lot, and there's some really good work that goes on from housing associations in helping people to kind of navigate some of those kind of labyrinthine systems that we've created in the world of health and social care, because actually it's quite complex. And then finally, social prescribing. Actually, many housing associations were some of the precursors to social prescribing, and were delivering social prescribing service way before we even coined the phrase social prescribing. And some of the first social prescribing pilots were actually funded by housing associations in places like Chichester. And there is more, and the work is going across the country on that. So helping people to leave hospital and live in less restrictive settings, and that's again an important part for us in housing. So housing advisors embedded in hospital teams, be they physical healthcare or mental health care, working to address those really complex issues around housing. We know that delayed transfers of care because of housing is a significant issue. It's a very big issue in the mental health sector. It's also an issue in the physical health sector. If we can intervene early, we can actually resolve some of those issues. And there are lots of examples across the country, Wakefield, Sussex. There's a whole range of examples of people with housing expertise working in those clinical teams, working as discharge support workers to really help resolve those housing issues. And all of that does is really helping that pathway flow and making sure people aren't stuck in the wrong place. Step-down beds is something that housing organisations have pioneered across the country, and that's improving pathway flow. So we see, for example, in Manchester, examples where a housing association is working with the local mental health trust to provide transitional housing. How do we get people out of the inpatient environment if they don't need to be there in the community, but they might not be able to get to where they need to get to. They might be waiting for some supported housing or waiting for further assessment. We can do that as well. Supported housing for complex patients. Actually, so this is like complex mental health, learning disability and autism. There's a lot of work that we are leading at the moment in London, in Bedford, Milton Keynes, in Luton, in Birmingham and Solihull, all over the country, in Devon, looking at how do we reform some of our Section 117 pathways for mental health, so that people living are able to move away from locked inpatient care, where arguably they're not actually delivering a good recovery service. To do that requires a whole new engagement with housing, but we're able to make that happen. Handy person services are really important. That's kind of it can be anything from I need to adapt a home to actually I just need to have a key safe on the wall so that the district nursing team can go in. Those things can be done really quickly and effectively by housing, and they're doing it across the country. And then finally, assistive technology and digital technology is something that we do. So housing as estate, as asset managers is an important thing to look at. So lots of work has gone on in different parts of the country to look at how does the NHS use its estate more effectively? How does it drive more value out of its estate? And can it do that with housing? What's resulted is actually new workforce accommodation that really helps with retention and recruitment. What we're seeing is NHS buildings being refurbished into supported housing and independent living environments. We even saw over COVID a whole kind of community hospital being brought back into use by housing associations using their skills to kit out what was actually being used as kind of more administrative for administrative staff to actually bring back into use a community hospital that had stepped down for COVID wards. This is a big issue. There's a lot of investment going on around disability, learning disability and autism and new build provision. But the other thing to remember is that housing associations are major regenerators. They actually do a lot of work in regeneration in communities. So how can you work with that and build good health outcomes through regeneration? Workforce, and this is some of the work that Susie's been involved with up in Cheshire and Merseyside. How do we? There's work going on all over the country to help social housing tenants into good NHS jobs. So doing like the pre-employment work, pathway work, but actually helping the NHS to break down some of its barriers around NHS jobs. And there are a huge number of barriers, I can tell you, in how that we have created in the NHS that stop people from getting to our door. We can provide workers in MDTs, as talked about that before, about expertise, but also affordable housing for staff around that helps recruitment and retention. And then the final thing is also, how do we think differently about the job roles we need actually to deliver good health outcomes? You know, do we need, for example, a care coordinator or nurses in mental health to do housing work? The answer to that, no, we don't. We actually need housing workers to do it. So all of this, for me, is framed in the other bit of the conversation we're having around integrated care, which is around anchors. So the NHS sees itself as an anchor institution, but so does housing associations, and as does local government, and as does education. So housing associations like the NHS are asset-based. They have a long-term stake in communities. They impact locally. They have a focus on social value. They want to work in partnerships. But the other two issues that come here is that there is a strong focus in housing around health inequalities. And actually, again, if you look at the core 20+5 and the health and inclusion groups, they're all people who are being housed often by housing associations. And then for housing, net zero is a massive issue, as it is in the NHS. So actually, we are working on shared issues. The question is, are we working on those shared issues together, or are we doing that in glorious isolation from each other? Final thing. So we have 4 key objectives for every ICS. So I'm going to ask the question, can housing help deliver the 4 key objectives for an ICS? First of all, yes, improving outcomes and population health. Our core perspective of housing is about good health outcomes, good housing outcomes. Yes, we can help prevent ill health and tackle health inequalities, and we can do that together. And we can, because many social landlords have the connections in the communities to be able to do that. The third objective is probably where we spend most of our time in the NHS thinking about. And yes, housing can help. We can help with pathway flow. We can help with ensuring that people are in cost-effective provision and they're in the right place at the right time to deliver the right care. And then finally, can housing help with the broader economic and social development? Of course they can. And in some respects, I might suggest that housing is more used to working around economic and social development than the NHS. So the NHS can actually work and build on their strengths and build on their perspectives to be able to make that bit work for them as well. So across those 4 objectives, by working with housing and collaboration, we can achieve those outcomes. There you go, Susie.
Fabulous. Thank you so much, Drew. It's just obviously any time I hear you speak, I just feel so enthused and like I feel like I've changed the world. So thank you so much for that. I'm going to ask people in our audience to raise some questions, whether it's in the chat, if that's okay with you. I do have a question I'd like to kind of pose to you. So you've obviously, as a non-exec director within the NHS, but also as a chief exec for HACT, working across the country over the last fair few years, what would you say is the main challenge around working in this arena alongside health and care? And from your experience of all those different projects and areas of work you're working on, what are the main challenges, and what advice would you give colleagues on the call today and those that are listening to the video What advice would you use to address these early when they're trying to do a similar sort of collaboration with their housing association?
I think there are two main challenges. The first thing is about how do we understand each other? There's a lot of misconception about each other. So as I said, the NHS doesn't really understand what housing does. It thinks it's something that local government does and really has no perspective of housing associations. So learning about who these organisations are, what they do, where they work, what they prioritise is important, but it works the other way around. So how do housing understand the NHS? And again, NHS is very complex. Probably most of the people on this call, we don't understand how the NHS works either, and yet we work in it. But so how we build that understanding of each other is a really big enabler. But if we don't do it, it's one of the biggest barriers because we just miss each other. The second biggest barrier is the NHS culture. In the NHS, because we're very well resourced, even though we might moan all the time about the resources we don't have, in comparison to other parts of our public sector, we are massively well resourced. We are massively operational organisations and people. What often happens when there's a problem in front of us, the thing we do is we go, how can I solve the problem? What we need to shift is to the question of who can help me solve the problem? If we can shift just that one question and that one piece of thinking when we have something in front of us we have to deal with to ask who can help me, we would undo a significant cultural barrier that exists within the NHS. Just ask that question, who can help me, not how do I solve it?
Perfect. That's fine. And in anticipation of today's session, I have a couple of colleagues that weren't able to make it but wanted to ask some specific questions themselves, if that's okay.
Yeah.
So it's like a bit of question time. One of them was around public health management. So it's seen as a key tool to prevent the decline in health and wellbeing in our communities. So from a housing perspective, how could social housing providers, as well as private sector landlords, particularly in those deprived parts of our communities, be played in to deliver the public health management agenda to ebb the flow of the crisis and the late presentation of chronic illness?
Yeah, so I mean, first thing I would say is that what social landlords can do and what private landlords can do are very different things. Because, as I said, there's 1,400 social landlords managing roughly the same amount of homes as 2.5 million private landlords. So at that local level, engaging with private landlords, they're very different engagement mechanisms of how you do that. And actually, social landlords do pay a lot more attention to the broader health inequalities issues and public health issues than private landlords do, because actually it's part of our social mission in social housing. Actually, what they can do is a range of things they should do. So first, they've got connection and access to people who health actually struggle to get connection and access to. They've got resources in the community that they can build upon. They've got insight and data about what's going on in the communities that they work in, and they've got solutions as well. So they've got ideas about how to make things work and what does work for the communities in which they serve. So I think the thing that I would encourage to health is that actually a huge role to play in population health management. Open up the conversation about what they can do. Come to the table and say what we want to do with our population is to work with this group, and these groups, because we've identified that they're the ones that have got and these are the things we want to do. How can we do that?
Marvellous. Thank you, Drew. Are there any further questions from the group? Nothing's coming through on chat. Anybody want to raise their hands and ask Drew anything? Andy.
Hi. Thanks for that, Drew. That was great. Absolutely great. Data sets, information and data sets, and somehow getting that business intelligence out of them across the sectors. What experiences have you had around that? And can you point us in any kind of directions about where you feel those data sets have begun to show value merging between health, social care, public health, whatever?
Yeah, so the experience I've had is pretty horrible and pretty hard, if I'm honest. Let's be frank. There is a real big challenge and massive barrier around information governance. And there's been a lot of conversations that say if we could combine the data that's held in housing with the data that's held in the NHS and with social care, actually we might be able to drive new analytical insight through that and might be able to prioritize and start to identify people. Most places that have tried to do that come across the information governance barrier, and it's really, really hard to overcome. And it's hard enough to combine social care and health data together, if we're honest. And we still haven't cracked that nut either. So when it starts to think about another sector's data, it's quite difficult. Let's also be honest, it's hard enough to actually get health data and health data to come together, you know, between kind of acute and primary care. And, you know, there's lots of, so we've got lots of problems with data, lots of opportunity. There's a piece of work going on at the moment in Liverpool, which is trying to crack the nut of the information governance. There's a piece of work going on in South Wales as well. So there's a lot of interest at the moment. People saying, let's try and crack this. Let's see what we can do. Put that to one side, because if we can crack it, marvelous. But actually, data isn't just about connected data. It's also about insight. It's also about the contextual data that we have. It's about the understanding we have about the communities that we work in and how best to access and how best to work with. Housing organisations, voluntary sector, all of those organisations that work in the community have that insight. So let's not just think that wait for the prize of connected data to arrive. Let's also work on the basis of let's share insight about places and neighbourhoods and about the people who live there, and let's work together at that as well.
Fantastic. Thanks, Answer. Yeah, I must admit, I recently came across some of the cipher data from Liverpool and how it's been used over the last few years, and it's quite amazing.
It is
quite amazing.
Yeah.
Thank you for that. And Professor Richards-Jones have put the link in for the cipher work as well. Rowan, I don't suppose you want to kind of say anything about that before we...
It's an absolute deep foundation that we're driving into the ground in Cheshire and Merseyside to link these data sets, and our entire programme of intelligence into action is already making a difference. So, for example, we can map nice guidance around defining cold homes and winter fuel poverty with high levels of deprivation. That's now overlaid with diagnosis of COPD and asthma, and those individuals are now being supported by community respiratory teams. And for example, in St Helens, of the first 52 that we found, 43 have had additional payments into their bank accounts from the government for fuel payments that they didn't know they were eligible for. 2 have had new boilers fitted. We've got insulation going in. Half are having medication reviews. And we're doing something similar for under 3s with asthma after the tragic outcomes of that toddler up in Bolton losing his life in a mouldy home.
Yeah.
We're doing exactly that sort of thing now to find those high-risk individuals, because there's no point sorting out a youngster's inhalers if they are living in conditions that are unfit for their respiratory condition. And now our local authorities want to look at their housing lists and how they would prioritise those on a housing list based on health need. So that's exactly the approach that we're looking to take to become far more proactive in this space. Thanks for the invite.
And two thoughts on that. One is that social landlords also want to know how to prioritise their own investment in their own homes. And social landlords, as a proportion, actually have the of those different types of tenants, has the lowest level of disrepair. That's only 5% of their homes have got category 1 hazards. But they too would benefit from knowing how to prioritise, because they want to be able to make the right difference. And the other interesting thing is that Liverpool's been at this for a really long time. So about 15 years ago, Liverpool did the JSNA, and they combined the Housing Health and Safety Rating System into their JSNA, and it started to identify those homes that were most who were in most disrepair, and they then started to unlock private sector investment into improving housing. Now that, you know, so we know that it can work, and we also know that investment and can flow into the right places. What it takes is a willingness to want to be able to do that. And it's great to know that this is still happening in Cheshire Merseyside, but I'd like to see this happening everywhere, because there's new research out today that actually says about from the BRE about the societal impact we can make if we just dealt with all of those homes that have got a category 1 hazard in them.
Thank you. Thank you so much, Drew. That was absolutely fantastic. I'll any more questions? I've opened the next Menti. So if you could all pop onto the Menti again, I'm just going to remind you of the code. and we'll set up our next set of speakers. Drew, thank you so much. As always, you're insightful, you're inspirational, and you just give us much more information around a part of the sector around health and care that I think a lot of us don't know about, or don't know as much about as we should. So thank you for that introduction. And any further questions that might fall out of this, if it's okay with you, do you mind if I share those with you so we can follow up, close some loops on people's understanding?
Please do. And if people have got, I'll stay around for a bit. So if people got stuff they want to put in the chat, just put it in, I'll answer.
Magnificent. Thank you so much, Drew. Thank you. So very quickly, because we're just running a couple of minutes behind. If you could just pop onto your Menti again, any reflections, and I won't turn the screen off until I get at least one or two of people. There we go. Thank you. So just some reflections, some key actions. Are there any take-home messages that you've heard today that you weren't aware of before? If you could just a couple more input on here, and then I'll hand over to our fabulous speakers from the voluntary charity, faith, social enterprise sector. I'm going to encourage, I'm going to put some hold music on in a minute if we don't get a couple more. Anybody else would like to pop something in? While we're waiting, and I will keep this up, Andy, do you want to just give a brief introduction to our next speakers, or would you like me to do that? Well, you're on mute.
No, go on, Susie. You carry the flow. Carry on.
Okie dokie. Well, I will hold people to putting some responses into the housing bit, but I'll have to change my screen again now, and I'll introduce you to. Oh, right, hang on, I'm in the wrong bit. Sorry, apologies. There we go. Here we are. That's the one. Okay, so we now got to look at in our next group of speakers. We are really lucky today to have three fabulous leads from the voluntary sector that can talk a little bit around their role within that sector, how they work across systems and how they work across places and with organisations, and give us some insight in some of the opportunities as well as some of the challenges about working in this sector. So we've got Kim Schuttler, who's the CEO of the Cellar Trust, and she's also the sector lead for the VSE in West Yorkshire ICB and is a member of that board, which is fabulous. So thank you so much, Kim, for coming today. Followed by Kim, we're going to hear from Dave Hyam. He's Chief Exec from the Well Communities CIC and is the National Lead for Lived Experience Recovery Organisations, which are really interesting. So you'll get some really valuable insight in that part of that sector. And we've got Ellie McNeil as well, who is from the CEO of YMCA Together, I think based in Merseyside. Ellie, am I correct? Perfect. So again, given that really unique perspective of the work she's doing, I know she's really passionate about population health and health inequalities as well, so it'd be great to hear from her. So without further ado, I'll stop sharing my screen and I'll hand over to Kim. I believe you're sharing your slides, are you, Kim?
Yeah, I will do, if that's okay. Let me see if it works. Has that worked all right? Is it come up?
Perfect. It's gone through. Oh, it's gone again.
Oh, it's gone.
I can see oh, it's back again.
We're there.
Yes.
Ah, now then, that's no good because that's what I might just give me 1 second there, just because that may it will look like I'm not.
Do you want me to present from my screen? Would that be easier?
Do you mind? I just
not at all. Let me just do that. You just stop sharing and I'll pop mine up for you.
Right, thank you. Trying to be clever and using a second screen and failing miserably. So thanks so much for having me today. So I'm talking to you from Bradford, and I've come to talk a little bit about the stuff that we're doing in West Yorkshire today. I'm from the Northwest actually, but I've lived in Yorkshire for a long time. So as Susie mentioned, I wear a couple of hats. And we're really proud that in West Yorkshire there's been quite a big investment in making sure that the VCSE are central to the partnership and play, an important role in delivering the ambitions. So I'll just talk a little bit about what we've been doing to make sure that we're focusing our priorities to really maximise the impact of the sector within health and care. And it was great to hear a bit of the last presentation, because I think actually there's quite a lot of similarities in some of the stuff that I'm going to say with social housing. So if we just go on to to the next slide, please, Susie. So so my role is quite a new one. So I think we're one of the only ICSs that has a VCSE person on the integrated care board, which is brilliant. And then I've got a little team of people, and the focus of that team, so Power of Communities, is about how do we really make the most of the sector in transforming health and care, and create the right conditions for that to happen. So I'll talk a little bit about that. Next, please. So we've been refreshing the things that we're focusing on in working with the ICB, because I think sometimes the way in which the sector can work, and I don't know if this is the case in the Northwest, but sometimes, certainly in our experience, it can be a little bit easy for us to come to the table and have a lot of gripes about some of the challenges that we're facing. And of course, those challenges are significant. There are huge risks to the VCSE at the moment in terms of its sustainability. We're flashing red on the risk register and those sorts of things. So it's really important that those things are visible within the partnership. But in terms of working with our colleagues, one of the things that we've been keen to focus on are, what I said is, we want to leave you with a fear of missing out, a bit of FOMO, because actually when we go out and ask systems and say, to what extent are you really making the most of the VCSE within your wider partnership? Actually, you know, it'd be interesting to ask that question in the Northwest, but certainly what we've been picking up in the conversations we've had in West Yorkshire is people are rating it something between like a 4 and a 5. They really don't feel like we're maximising the potential of the sector. So that's exciting, because it means that the potential is really, really great. And this is a bit of an overview, but if we go on to the next slide, I'll talk about some of the things that we've picked out of where there's some opportunities that we're really not maximising. 95% of the VCSE nationally is small or micro, which means teeny tiny, mostly working in localities, grassroots organisations working with specific areas of the community. And in general, when people think of the sector, they will often think about those organisations, which of course are amazing. They're like gold dust organisations in the work they do, particularly around health inequalities. However, we have some fantastic opportunities to look at where there are examples of where we're not maximising what the sector can deliver as complementary or alternative to different pathways in more clinical services. So I identified acute and specialist provision as an area where we'll be focusing on to try and accelerate the practice, look at how we might level up some of that practice across our different areas of West Yorkshire. So with my day job hat on, I've got staff based in both acute hospitals. They're peer support, mental health peer support workers working in a multi-agency support team alongside drugs and alcohol workers, complex needs social prescribers, frailty workers, and they are all based in the A&E departments, and then they follow up with people in the community, specifically working around admissions avoidance and reducing delayed discharge. And there are other examples of that, but there's certainly lots of places that aren't doing that yet. And I guess I would, I'm sure there'll be acute care colleagues maybe on the call that perhaps aren't thinking of the sector as a potential solution to some of those things that we know that NHS England are very interested in, and we're all really interested in. Other interesting examples of things going on that perhaps not being maximised yet are specific initiatives to tackle growing waiting lists. So some interesting work going around things like using peer mentoring and buddies for people on CAMHS waiting lists. And in Bradford, I know there was some real success around that, where people were experiencing very long waiting lists, and actually by having some peer support, some buddy support whilst they're on the waiting list, they either did not end up needing CAMHS, or they were certainly waiting well. And we know that people are often sitting on these waiting lists and not waiting well, particularly where people are experiencing high levels of health inequalities. So those are just a couple of examples there. If we go on to the next one. So community and neighbourhood work is, it's our bread and butter. That's where that 95% sit in the main of the sector. most of you will have know about the fuller stock take, all the work that we're doing around primary care networks. How do we really work in localities? And that's why when I was listening to the previous presentation about housing, I thought that was really interesting. Community anchors, I think, are a different anchor type organisation than we were talking about in the last presentation, but actually some of that, the role of community centres and community anchors in localities, and using those as a way to coordinate and build capacity of those grassroots organisations and shift power to communities themselves, is fantastic. And there's some really great examples of that. What we probably haven't got is that consistency of practice across the place and the right models and metrics always in place to evidence the social, the value in, again, the way that perhaps NHS England might like us to do that. And so we're doing quite a lot of work on data and metrics to make sure that we can develop some common data sets that allow that to feed through into some of the performance data. Next. And of course, you know, work around access and inclusion and working with our diverse communities. It's the same in the Northwest, you know, that our rich, diverse communities add a great vibrancy to the places that we live. Some of the highest levels of health inequalities in West Yorkshire. We know from COVID that actually those grassroots organisations in localities were the best at reaching people. Some really amazing examples of how vaccination uptake was accelerated as a result of integrated partnership working with the VCSE. Have we carried that through in terms of how we've commissioned and worked with the sector to take forward other things around health and education, etc., or health improvement? I'd say probably not consistently. A great opportunity there to think through, because if you go out and ask those organisations, they will tell you exactly why pathway X, pathway Y X services aren't working for the communities that they serve. And we don't always bring those voices to the table to hear, because they've got great insight into the communities that we're working with. Next, please. Workforce, I think it's a really important one. So, you know, so it's at the top of everybody's list in terms of challenges, probably alongside money. And actually, you know, we have in West Yorkshire have some sort of 53,000 people working in the sector, plus volunteers. And there's some great opportunities around different types of workforce to explore. So in my own organisation, which is called the Cellar Trust, we're a mental health charity, almost all of my frontline staff are peer support workers working, you know, and with a clear career trajectory, working through the organisation, delivering everything from employment support to crisis services to specialist trauma support. And they are trained and supervised to deliver that work. Some great opportunities, I think, to reflect on how might that be accelerated? What might that look like if it was operating at scale? We have a unique ability in our sector to recruit people from the communities in which they live, and to develop that capacity and those skills and routes into employment, working with the sector at that grassroots level. There's a really great opportunity to reach people in a way I think that statutory services sometimes cannot. Next. So I suppose that this is the last one, and I won't go into it in great detail, but this is one to think about, is that you can't maximise the impact of the sector unless you create the right conditions to do so. And, you know, there are quite significant barriers, as I think Andrew talked about before, in terms of the interface and for the sector working with NHS, you know, and so we have, you know, we've taken a paper to our integrated care board with an action plan of how do we create the right conditions to allow the sector to thrive within the partnership. That's not all about money. Of course, money is a massive factor, but actually sometimes it's about behaviours. Sometimes it's about practices, certainly around commissioning. How do you remove the barriers for those small grassroots organisations to be part of the conversations, but also to access the funding? Because I don't know what it's like in the Northwest, but I would take a punt that it's similar nationally, that the majority of the money that goes to the sector will go to that 5% of organisations, the big, large ones that are either regional or large local charities or even national charities, rather than going to that frontline, grassroots, locality-based work. So if we're thinking about our risks around health inequalities, what does a left shift resource look like, and what do what other things might we put in place to safeguard those fantastic organisations, but also to grow their capacity and work together to transform health and care, which I think, you know, we're all here for. And I think I'll end there, Susie, because I think I've probably gone on longer than my allocated time. So really, yeah, we can share the slides afterwards if helpful.
Thank you so much, Kim. That was fantastic. Loads of information. We'll put more questions towards the end if that's okay. And I'll just hand straight over to Dave. Dave, do you want to drive your own slides, or do you want me to do that for you?
Yeah, I can I do it from here, or do we need to upload it?
I can stop sharing my screen. You can share your screen if you want to do it that way.
Yes.
Perfect. Okay, let me just.
Is that me now? Is it? Or have I done something wrong?
Hang on.
What can you see? Hello?
Oh, have we lost Susie?
Right, have I got it? Yeah. Can you see the presentation, guys?
It's just loading up. Yeah. So if you go to slideshow, then it should ping through.
Yeah. I can't see yous now.
We can see your presentation.
We can see you. I'm back again, Dave. Sorry about that. I pressed the wrong button. So I'm back again.
Can you see me, guys? Can you?
Yeah, I can see at the top, and I can see your presentation.
Ah, lovely. I can't see you, so sorry about that, guys.
Yeah, David, it looks excellent.
Oh, bless you. Thank you. Well, I'm Dave Hyam. I'm the founder and chief exec of the Well Communities, which is a lived experience recovery organisation, meaning everyone at the Well has got lived experience of addiction, mental health, alcoholism, trauma, homelessness. And I founded the organisation in 2012. And we coined the term LERO in a national movement that I'm one of the founder members of, which is a national movement supporting lived experience recovery organisations across the UK. And we work with OEDs and around government, around policy change. So we fed into the Dame Carol Black Review, Part 2. We fed into the 10-year drug strategy. We fed into the national standards for drug treatment. And I'm currently working with OEDs on the recovery support services and national standards for lived experience recovery organisations. So that is really giving a voice for lived experience and how we can commission LEROs across the UK, but also how we can grow them. So the work we do using lived experience when people come into our organisation, these are the kind of people that we deal with. You know, do we see people like this as the problem or the solution to our problem? So we don't just work with the low-hanging fruit. We work with most complex people within our communities, from drug-related death right up to recovery support and mental health, the trauma, addiction and offending. And this person's name is Jed, who presented to us in 2015 with multiple complex needs, mental health, trauma, addiction, offending. But what we see, we see the asset within this person. When this person rocks up to our organisation, we see behind what we see and identify the asset, identify, you know, the strength in this person and how we can help and create the right conditions in order for people, you know, to recover. And that is the key under everything we do, is the 6 core conditions. But that's another presentation in and of itself, is the 6 core conditions. But what we do is create the right environment for this person to recover. And this person come into our organisation with over 200 repeat episodes of adverse childhood experiences, and that's from sexual abuse, emotional abuse, neglect, parents in prison, mental health issues, and we're creating that right environment. We supported this person, and this person now, since 2012, you know, is in 8 years in recovery. He's now our business lead of the Well Communities, and he's had multiple awards, and that's an award of the police and crime commissioner. So Jed has now come through, and we have a model called Grow Your Own. So the very people we help and support, they're our next generation of staff. They're the next people that will lead this organisation and embedded in the communities, where they're self-sustaining their own recovery, their own mental health and their own well-being, because it just keeps fed up. And we've got about 70 staff, and 60% of that staff is the very people that come in just like Jed. So how we see the current landscape is, we keep trying to build this bridge from services to community, from prison to community, from police stations to community, from treatment centres, rehabs, hospital detoxes, GPs. But people keep dying before they even get to that community. If they come out of prison and they've done some work within the prison and they're going back to their own community, some people don't make it and have relapsed and overdosed. Same with rehab, same with hospitals. We keep trying to build this bridge, and where there is no recovery support, there is no coaches. We have a companion model that is actively engaged. We're starting to see changes within this, down to the Dame Carol Black review. But what we do at the Well, we try and do away with the bridge and have no bridge. And the work we do, you'll see on our hub and spoke model coming up shortly. But the work we do from hospitals, going round and walking, doing wards walk rounds and sitting and engaging the people, the work that's being done in the prison, the work that's being done in the substance misuse service, in mental health services. We work with dual diagnosis within the hospital and in the community. So we're bridging that link. So the Well is the key, for them services and linking them up. So there is now no gap. So we, as a lived experience recovery organisation, bridge that, where we do away with the bridge, but then we create a recovery community, which then starts to sustain people's well-being, mental health and their recovery, overcoming addiction and mental health and overcoming their trauma. But what that also does is engages people in the wider community, because then people we support and manage and help them play in that community, they work in that community, they recover in that community, so they then become a citizen. And then we start to fertilise the soil, so it links in. So fertilising the soil, this is an amazing man, William White, and he says the community is the soil in which such problems grow or fail to grow, and in which resolutions to such problems thrive or fail to thrive. So what he's saying here is what traditionally happens, and you can't, if you look at my little picture in the corner, so I'll use a pen as a plant. So what we see as services is, say, look, here's a plant and it's dying, and it's embedded in our community, and we say, if we do not do something now, this plant is going to die. What are we going to do? Well, I'll tell you what, let's rip this plant up from where it was planted, and let's find this beautiful house on a hill with lovely soil, and we'll replant it in this beautiful soil, and we're going to talk to it, we're going to nurture it, we're going to love it, and then suddenly it starts blossoming again, and we see it flowering, and it's at its full bloom, and we turn around and go, look, we've saved this plant's life. Absolutely amazing. We start giving ourselves a pat on the back and saying what great work we've done. But what are we going to do now? Well, let's rip it back up and plant it back where we got it from. And we wonder why the plant is dying again, because we've planted it in unfertilized soil. We have a saying at the Well, if you sit in a barber's chair long enough, you will get an haircut. I guarantee it. And what that means is, if you're around people that are taking drugs, you will take drugs. If you're around people that are offend, you will offend. If you're around negative people who are suffering, your mental health will suffer. So it's about how we fertilise the soil in our communities. And that's what we do at the Well. We fertilise that soil. So when we're working with the people in the services, treatments, prisons, GPs, wherever it is, when we're supporting them, we help and maintain the soil they're replanted in. And we use this by our hub and spoke model, and this becomes a whole way of working where it's a whole system of care working together. So we have contracts in, family support, community carers. We have a carers contract with the main, one of the main suppliers of substance misuse treatment in Cumbria, in Lancashire. We have One Click, which is a County Lines Inform Cumbria. We're reducing with the police. We work hand in hand with the police to reduce the county lines, but picking up and supporting the vulnerable people. We have social prescribing with the PCN, so we're inside the GP surgeries, working with the GPs, helping people, getting them and linking them in to the support that's available within the community and by ourselves. We have a Changing Futures contract within Lancashire and in Cumbria. We had food clubs. We have two social supermarkets. So not only do we provide services, we provide a social supermarket for those who are in poverty and sourcing stock across the UK and selling it less than half price at a reduced price to that wider community. And then that social supermarket comes a referral pathway because the people that are accessing it might have mental health issues, addiction, drinking problems. So we're able to support them there and then link them into our services. So there is, again, no bridge or, giving them a leaflet and saying, go in there, because as Hillary Cotton says, there's no love in a leaflet. We have the New You PSI substance misuse contract within Lancashire. We have a 7 days electronic platform. So that's right through the weekends, offering that support. So that out of hours, we're not just a 9-to-5 services. We work in the hospitals. We work in Lancaster Hospital. We work in Furness General Hospital, and we work in North Cumbria Hospital. Again, doing them wards walkarounds, doing the support within the hospital, the intervention, hand in hand with the GPs and the nurses within there. And what we also have is supported accommodation, 24/7 support, because if you were someone like me who's been in the grips of addiction and in and out of prison for over 25 years, I need more than 2 hours support. So what we do is a full structured support, 7 days a week, 24 hours a day in our accommodation. And then with all the wraparound support that's available, we become the cog in that whole system way of working. So we're linking in. So there's no gaps within the way we work, for people to fall through, because from hospital to GP to the mutual aid community, to hospitals, to housing, to community support, the Well is integrated. So the Well is integrated that soil where now, people can get that support. But not only that, the communities come a safer place to live for everyone, because when our guys get well, they get better than well and go out. And our ethos is go out and be of service to your community. Go and help your neighbours. Go and help, that community centre or that church or that woman whose garden's overgrown. Go and be of service. So our ethos is go out and give back to your community and help it make a safer place for everyone, because you once took from it. It's now to give back. Thank you, guys.
Dave, thank you. That's amazing. Thank you so much. Just inspirational and fabulous. I'm struggling to articulate anything. I don't know how to follow that, so I'm going to leave that to Ellie to come after. And then we've got some questions at the end, which I'll share with all of you. So thank you so much for that, Dave. It's just, again, inspirational, and yeah, Ellie, would you just like to introduce yourself, give a bit of an understanding of where you're coming from and what you want to kind of talk through? Is that okay?
Yeah, that's fine. I'm just going to I'm just going to unplug the other screen. Sorry, let me just find my my computer's really deeply slow today. There we go. Don't think I want to follow Dave. That's all right. Is that come up for everybody?
Perfect.
So my name's Ellie McNeil. I'm Chief Exec at an organisation called YMCA Together, and we work with people experiencing kind of challenging times in their lives. And I was just going to start off with a bit of a kind of story. So this is Jack, and Jack has multiple underlying health conditions associated with his drug use. He's really underweight. His physical and mental health are really poor, and we've noticed a real decline in his physical health, and that's been of concern for some time. He came to collect his methadone late one evening and was really struggling to walk. Both of his legs were really swollen, and he needed to urgently attend hospital for a blood transfusion. He said that he was really frightened to attend due to his addiction, and that he was torn between attending the hospital and ending his life. And that isn't an unusual story for the people that we are working alongside. So people experiencing homelessness suffer from some of the worst physical and health inequalities than any other population of people. The life expectancy for someone who's experienced homelessness is 47 for men and 43 for women. And in a study that was done by an organisation called Homeless Link a number of years ago and then repeated in 2022, the unhealthy state of homelessness, they found that 63% of people that took part in the study had a long-term illness, a disability or an infirmity, and that from 2014, 45% of people reported a mental health problem, and in the 2018 to 2021 cohort, that had risen to 82% of people. Inevitably, 45% of the people that completed the study found that they were self-medicating with drugs or alcohol to help them cope with their mental health. And when we think about a kind of population health approach, the people who have some of the worst health inequalities in our systems often take up huge amounts of time and care from the health system, or they take up none at all, and they are a hidden population who only access help and support right at the last moment when their health is really, really poor. And so a lot of the work that we do at YMCA Together is to support people around their mental and physical health. And we were established in 1846 to address the social problems at the time. We're a Liverpool-based organisation working across Merseyside. So we were established to focus around child poverty, problematic alcohol use, literacy challenges, worklessness. And in 2023, all of this time later, actually, the communities that we work in are still impacted by all of those same things. Today we're working with around 1,500 people each year, providing over 400 units of accommodation, and we work using a psychologically informed model of working. So when Dave was talking about the seeds in the soil, it's really interesting because we use an approach called cognitive analytic therapy. It's a relational approach, and it's about us thinking about what we can do differently. And often services expect somebody who has experienced absolute trauma, who is in the throes of addiction, who's got really poor untreated mental health, to step into a service and change. And actually what we do is think about what can we do differently. So what can we do differently as a service, as an organisation, as a system, to in turn invite something different from the people that we work alongside. And we talk about a reciprocal relationship between the seed and the soil. So the system has to be in a relationship with the person that needs help and support in order for them to be able to get their needs met appropriately. And so we use that approach, that relational approach. We train all of our staff in thinking about how they can do things differently. What do we bring of ourselves into our workplace? What do we bring of our own pasts and our own histories? You know, what we'll find is that some people will be on one end of a kind of spectrum of kind of strength, and then other people will be on a kind of the kindness and compassion. And what we work to do is to try to kind of balance our workforce to offer the best possible value-led approach to the people that we work with. So we work alongside, across our services, people experiencing homelessness, domestic abuse, problematic drug and alcohol use, and mental health issues. And then when we think about the voluntary and community sector in terms of a partner in systems leadership, I want you to imagine that you had one person representing the whole of health in your system. So one person on a core meeting representing the whole of the NHS, primary care, secondary care, specialist provision, public health. They need to know all of the budgets, the targets, the outputs, the outcomes, and we have that expectation for the voluntary and community sector. And often we think that at key meetings, at key decisions that our systems, our cities, our places, our ICSs are making, that one person is good enough, and it just isn't. And similarly to what was being said earlier, I think that the system misses out. It misses out on that different approach, that different way of thinking, the genuine, when you hear Dave talking, that kind of genuine connection to the communities. And actually the voluntary and community sector is such a part of the solution. And we saw that through COVID. Populations that core services weren't able to engage with, weren't able to get the public health messages to, weren't able to support people to uptake the vaccine. We saw the voluntary and community sector doing that piece of work. We saw them close to their communities. We saw them as a trusted partner, and the people in our communities who were frightened of what was happening around them knew that they were a trusted partner, and therefore vaccinations were taken and public health messages got out there. We're a sector that is flexible and responsive and dynamic in our DNA. We, for our organisation, as the pandemic hit, we work in partnership with our local mental health trust, Merseycare. Mental health service within 6 weeks, a new building, a new workforce, all kind of done and ready because of the pressures on their wards. We can do that in a way that most other parts of the system can't. We're experts in the health inequalities of the populations we work with, experience, and we are, because most of our services are co-produced. We're working alongside the people in our services in everything that we do, and it's such a kind of key part of the work that the sector does. And I think there are some really kind of quick wins for effectively engaging with the sector, and I also recognise that it can feel really kind of woolly, and there's so many different organisations, and there's so much to kind of think about, and who do you connect with and how do you do that. But actually, one of the first things is that connections and good governance is really important. So over the last 12 months, I've been doing a secondment into the Integrated Care Board at Liverpool Place, leading the population health segment around complex lives. And through that work, there was really limited voluntary and community sector involvement in the ICB at kind of place level. And so we have established a strategic health and wellbeing network, and of that network, we've now got nominated reps onto all of the different population health segments and onto the main delivery group. Not just kind of a single person, but 2 or 3 reps on each of those groups, bringing their expertise, representing their organisations, the sector, but also the work that they're doing in that expertise. We touched on earlier that importance of accessible commissioning opportunities, and utilising your local CVSs to be able to do grant opportunities for those small grassroots organisations. And there was a story that kind of stuck with me from an organisation that was working in Liverpool. And they provided cycling activities, and one of the gaps that they found was that women from the South Asian community struggled to access that because they had specific needs, and they wanted to have a women's only group. And they set up that group really kind of, they went out cycling once a week, and the health and well-being of the people in the group massively increased. Their access to health screening things like smear tests and those kinds of things increased because they were engaging, they were talking together, they were reducing the stigma of access. And but it was tiny. you know, that was maybe a few £100 a year investment. And when the big commissioning opportunities come out, they're so far away from that. And so how do we harness the power of those grassroots organisations in the way that we kind of think about commissioning opportunities? Parity of esteem. You know, the voluntary and community sector should be seen with an equal footing and an equal voice. We aren't a poor relation to the work that's happening in systems. And actually, I think that without the voluntary and community sector, our health systems would collapse very, very quickly. Often we are the prevention and early intervention, and we're also the crisis. And we're supporting people at either ends of those spectrums. And we need to be seen as an equal and strong partner in the work that we do. But also to have the right to hold to account the people and organisations leading in the system and be able to provide feedback without fear of reprisal. So we often kind of walk a tightrope of being commissioned by organisations that we also then need to give some feedback about how things sometimes aren't good enough, and all of us walking into the room as adults and being able to have those conversations that can sometimes feel quite difficult. Something that we're really passionate about, and that Dave spoke really passionately about, is that genuine engagement and co-production for people who use services. So co-production doesn't mean going with something that's finalised and asking if it looks all right. It means involving people with lived experience right from the start of things. And how do we do that in a much more effective way? And the voluntary and community sector can be a gateway to supporting that genuine co-production. And then there's some of the kind of really important things, but things that feel really easy as well. So where there's training opportunities in your systems, open them up to the voluntary and community sector. Where there's leadership opportunities in your systems, think about secondments in from the voluntary and community sector. And if all of that still feels really hard, think about what you can do personally. So there are organisations out there in your communities that are desperate for skills and expertise on their trustee boards. How can you get involved in your local community yourself by becoming a trustee? I think that's also a really, really important part of the work that goes on, and ensuring that the charity sector has really good governance as well. That's everything from me.
Thank you so much, Ellie. That was amazing. Just a personal reflection of all three, because I know we're running a little bit over time, so we'll rush straight to questions in a sec. The work that the voluntary charity faith sector does is just phenomenal. It is at the grassroots. It has real impact on the community, and you have real knowledge of what's going on in the community and the best way to support them as well. Since we've been trying to plan for this session as well, the conversations I've had with each and every one of you has inspired me on a personal basis, and I've recently become a trustee myself because I want to give something back. So thank you for that opportunity. Very quickly, because I know some of you have to go, I just want to ask each of you, and I'll go to Kim first. We've got a lot of different types of clinical and care leaders on the call today. What is the one thing, the one change you want them to make that will enable that improvement of those relationships, of the engagement with the voluntary sector, that you think they can do as an individual within their organisation or within their system? So Kim, I'll come to you first.
I'd say create the spaces for the conversations and shift the relationship, because we may create change through relationships, and actually the sector's very, Ellie's mentioned, but the sector's so good at coming up with innovative solutions, and we can only see our own bit of the world sometimes. So sometimes go with it. If you go with a challenge or a problem, our sector is amazing at coming up with solutions you might not have heard of. But if you don't come to the table or go to their tables or bring people to your tables for those conversations, you're really missing out on that broader view. And you'd be surprised at the solutions that can solve really, really complicated system problems if you have the dialogue.
Thanks, Kim. Dave?
Yeah, I think mine would be, you can't be all things to all people. Don't try and create a wheel when there's a wheel already in place. The best people to do that is the third sector and the lived experience recovery organisations. What I have seen is part of the NHS trying to recruit lived experience and trying to manage lived experience, but with no idea how to manage someone, support someone, and supervise someone with lived experience. Case of relapse, can they identify, a relapse, drinking, in substance misuse? So if there's a Lero within your your area, then engage with that Lero and work with them and partnership with them and contract them Leros, because we're seeing it now, you know, direct commissioning for lived experience organisations and the third sector. And one more thing is when we are commissioning third sector is the salary disproportionment. When we've had a contract, the salary was 23 to 26. When the NHS themselves were employing that person, they had a 28 to 30. So there's like a disparity within these salaries. So we invest and respect the third sector, because they're professionals in what they do, in what we do, and it's being respected and such, and have that equilibrium of power and respect.
Thanks, Dave. Really important stuff. Thank you. Ellie, your same question to you.
Yeah, and I guess it kind of follows on a little bit from what Kim and Dave said, but clinical roles aren't always king, and often the same job can be done in a really good and effective way through voluntary and community sector organisations that previously might have been a clinical role. And I'm obviously not talking about GPs and those kinds of things, but there are roles that go out and we struggle to recruit for, and it leaves recruitment gaps that actually that same piece of work could be achieved by the voluntary and community sector in a different way with a bit of kind of different thinking. And then the other thing that I would just say is to look around your tables at the meetings that you're in and see whether your community is truly representative around that table, and kind of going back to that kind of parity of esteem that I raised before.
Fantastic, thank you. We've had a couple of comments from Andy McAvely, who's from NHS Cheshire West, I think it is, and he's just reflected on, apparently in Liverpool there is a CEO of Cheshire West Voluntary Action Board is on the Cheshire Merseyside ICAB board, which is fab. And he's also expressed that his previous mentor was from the National Voices, which was a lived experienced organisation, and he gave him terrific insight and help into his leadership role. So again, some really good examples that other members on the call today and those that are listening to and watching the video can maybe pick up. Does anyone, I'm just mindful of time, do you need to go, Kim, because I know you had to scoot off, and Dave needs to go as well. Okay, well, what we'll do, I've got a couple more questions, but I'll put those out, and then if you can give us a bit of feedback, if that's okay, and then we can make sure we include that.
I can stay a few minutes if you've got more questions you wanted to ask.
Okay. It was just one really. We've talked about it, and I think you've touched a little bit about it in some of your answers. But again, thinking about your sector and, you know, the complexities and the variety of different types of organisations there are. Dave, if you need to go, you're very welcome just to go as well, so don't worry. But how do we grow that voice? You know, recognising on the table, but is there something? I know you've done a bit of work, Kim, in your sector around enabling that voice to be larger and louder. Ellie, you talk about parity of esteem and making sure that, you know, people welcome, engage, respect, and actively pull on that expertise within the BCFSE. How do we do that? What would be the ideal solution if we thought about this as a whole system perspective?
I mean, the reality is that you've got to resource it properly. Yeah. And in so many areas it isn't, because there's sort of there is the expectation and sometimes a feeling that people should feel grateful for being invited to come to meetings. And the reality is that the majority of VCSE leaders will be having to make a choice about, are they going to do something to, and so, if you think of 95% of the sector is small, when you've got a charity chief exec, they're also simultaneously probably delivering frontline services, writing funding bids or whatever. So are they going to make a choice? Yeah, exactly. Cleaning the toilet, whatever, amazing multitaskers. Yeah. They'll have to make a choice where they're going to go. And so if you really want to have a diverse voice at the table, you have to create the structures for that to happen, which includes resourcing it properly and thinking what the barriers are. And mostly for the small organisations, the barrier is time and the organisational cost to them. And then work through your infrastructure organisations, and some of those will be well resourced to have that infrastructure to grow their capacity and to create the linkages in. And Ellie sort of talked about some of the stuff already, but lots haven't. So do it meaningfully and do it and if you really want a diverse leadership of the sector involved, you have to do it intentionally as well, to find those people to, you know, to be involved.
Okay, thanks, Kim. Anything to add to that, Ellie? Or
No, I think Kim's summed that up really well.
Brilliant. I mean, for all the presentations we've had today, it's all been really about that values-driven leadership, and that's the one thing we can all coalesce on, isn't it? Whether it's in health or care, housing, or the third sector or the BCFSE sector, you know. And it's how do we enable that, empower that? We've talked about networks and the stuff that you've been doing, Ellie, and how do we bring networks together and really empower them? So, listen, thank you so much, Angie. Is there anything else you'd like to ask before we just move on to the last bit of the section?
No, not really much. It's more a comment of how inspiring the three of you have been, and Drew before that. And what struck me before our previous meetings was how people really began to understand that the wider determinants of health and its other organisations like yourself that often get into those arenas more is so powerful to the health and well-being of the individual, rather than individual organisations seeing just part of the individual. And this is inspirational stuff that we need to find ways of getting those communications going, getting those meetings going, and getting those discussions and understandings going, so that we can see more clearly how we interrelate and support the people that we're all trying to help. So it's really just a thanks and a hands up to say that how well your talks were, how good they were. Really, thanks.
Thank you. We're going to thank you both very much. We're just going to go to the Menti again. This is the painful bit where I just pause for ages, hoping we'll get some interaction. So bear with me. I'm just going to flick to my screen now. Okie dokie. So we have had some feedback for the housing section for Drew last time. So thank you for filling those in as we've been listen to the next lot. So again, same question from the three fabulous conversations we've just had with our BCFSE colleagues. Have you got any reflections? Have you got any actions you want to take forward from that? We will be going to this a bit more in the breakout sessions, but again, some initial reflections that come on from there. Well, I'll just keep that screen on just to kind of hopefully guilt some of you into giving us some responses. Thank you. We will be going into our breakout sessions now. I know everyone's really busy and it's very time pressured, but I would give you a strong plea. Please join us for the breakout sessions. We want to be able to start digging in a little bit deeper into this. The output of these three sessions, this being the last one, is around bringing that clinical voice front and centre. So we will be pulling together a report that we'll be sharing with NHS Northwest, who commissioned us to do this particular piece of work, and the three ICB footprints as well, so that all the challenges, all the opportunities, all the passion that's come from these last three sessions can be brought together. And that really comes thick and true from the breakout session. So please, if you can, please do stay on for that. Thank you for your comments for the BCFSE. Amazing work, inspirational, absolutely, absolutely fantastic. There's a question here about how do we spread the word on the fantastic work you're doing. So again, thinking about, I think maybe there's an opportunity to link in with ICB colleagues, as well as kind of the larger organisations that kind of co-host some of the local charities and voluntary services. Inspirational, thought-provoking. Parity of this seems really important. And we need to make the time, which is always a really difficult thing with all this, don't we? About how we get the problems together. How can we use the networks to kind of make this happen? So thank you for that feedback. Keep them coming. I'll keep them in the background as usual. But for now, we are going to go into our breakout sessions. So we've got the fabulous Dawn, who's our guru when it comes to the teams. You'll automatically get slotted in to one of two breakout sessions. I've got a lovely lady called Claire Wild, who's going to facilitate one. I'll facilitate the other. And again, it's just more of a discussion, reflections, but also we'd really like you to focus on some of your personal actions that you want to take forward as an individual. From what you've heard today, what you're going to do in your leadership role to kind of drive that forward. We'll also, any of the challenges you think you might come across when you're trying to do what you want to get out of this, we'll capture that. So again, we'll bring that together in the report that we're going to be sharing wider. So Feel free to talk as freely as you want in the sessions. Everything will be treated with confidentiality. Nothing will be assigned to any particular person, organisation, or even geographical footprint when we report on this. So, you know, we just want to hear your voices. So without further ado, we're running a couple of minutes late, maybe a bit more than a couple. Dawn, would you like to pop us all into our breakout rooms, please? All of that data that you've shared with us in the breakout sessions, all the key messages that our speakers have talked us through over the last 3 sessions, and we'll be sending that as a report to colleagues. We'll be sharing that, we'll be discussing it with them. We had one of the ICB execs on earlier today, so he was able to hear that firsthand. But if there's anything, and you don't have to do this one, but if there's anything in particular you want to make sure that is loud and clear as a message that goes to NHS England, that goes to your local ICB in terms of what you feel the opportunities are or what you feel that you want them to do, that would be fantastic. So have a little look on your Menti, put something in if you can, and just to let us know what your message is, what your plea is to those that have got the ability to make some of this change. I'll just give a couple of seconds for that.
Yeah, and Susie, we definitely had those kind of things coming out of our little discussion, definitely.
Marvellous. And we will take that as well. So sorry, Anna.
Sorry, lost the code again.
Oh, you lost it. Okay, she'll pop it back up again. Just 2 seconds.
Oh no, I found it. It's on the chat.
Oh yeah, you found it. Perfect.
Thank you.
Thank you. So if it's okay with my group, because I forgot to ask someone to nominate themselves to speak, and it'd be a bit mean to do it now. If I just do some key reflections of the conversations we had, and if the other group wants to do the same, and then we'll just finish it off then with a final review of what the key messages are and any feedback you want to give us for the session as well. So we had a really, really good discussion. There was in terms of our team that there was a few that were already doing some really active involvement with the voluntary charity faith sector, and finding real benefit to that, and they were incorporating that within their structure. Others felt actually this is a bit more distant for me because I'm working within a more acute surgical focus area, so the kind of that natural link you'd have with your communities isn't there. So we explored opportunities around some of their cohorts were around with the veterans as well, so there's opportunities to think about how you look at your patient flows coming in, thinking about complex lives, and then in turn thinking about the VCFSE sector in that sense. We talked a little bit about funding as well, and that was a powerful message that came from that last set of conversations that we had with the VCFSE sector around to do this properly, and to, instead of saying that we need to have parity of esteem with our colleagues across the third sector, actually we do need to resource this properly. Where is the funding, and how does that get motored through? We then talked, obviously everyone was really passionate about wanting to do something more with both housing and the VCFSE sector, but we had a bit of a discussion then about the realities of working in today's NHS, the pressures of just dealing with the levels of demand, the levels of complexities, you know, winter planning when we already feel like we're still in the last winter, and the winter before that, and the winter before that. You know, it's feeling pressured at the moment. So whereas there's a real opportunity to help with some of those demanding pressures, actually there's no space, there's no time to think that through, because developing those relationships is really challenging in and of itself, notwithstanding the fact that we've got the operational pressures and the firefighting that we all feel that we need to do. So there was we talked a little bit, and this has been a common theme throughout all 3 of the sessions. How are we supposed to do something which strategically is really beneficial and will really have a positive impact, but we physically have no time and no headspace to do that in at the moment? So that, again, I think that's something that as a CLN we need to think about how we can support that, but also working with NHS England and working with our ICB colleagues, what they can help put in place for that as well. There's another great comment as well around, you know, VCFSE for the patients, absolutely, everyone was brought into that, but there's an opportunity there to think about how we can use them and commission them for the well-being of our own staff in the conversation about us feeling all really pressured at the moment. A colleague was talking about in their area they'd thought about having a day in a year of a member of staff going out and volunteering in their local communities and having a day away from the day job and volunteering directly in the community. So that's actively giving something back. It's starting to develop those relationships with your charity. It'd be a really great way of doing that. So again, thinking about different ways we can engage with our VCFEC sector was really good. And I think that covers it. Anything else I've missed, team, from our breakout session? No. Magnificent. Okie dokie. Claire, anything come from yours?
Yeah, I mean, we were a small group, but we did have lots of discussion, lots of passion as well from our two clinicians that joined us. I think some of what, I mean, it echoed what you said really, Susie, just then. But I think there was certainly a conversation at the end about a behavioural shift needed in the system to be able to use this work, and how do we do that? Formalising, maybe using the network through action learning to see if we can come up with formalising a principle and an offer. And you know, giving that to NHS England to be able to give us permission back to be able to use that in our core day job. Andy, is there anything that you want to add?
I think you hit it on the head. And definitely the general feeling that understanding these wider determinants of health in a venue like this, rather than just in our day job, it's clearly obvious how important it is to the people, the patients that we're managing and helping. But how do you make that connection more effective within your organisation? Who do you do it with? How do you do it? And the other one was the very astute comment that political change seems to always drive what we do, and we're about to be moving towards a general election, and that could put everything on freeze again. And then comments really about well, perhaps we as clinical grouping should be advising the system that we need to be moving forward in things, even though commissioning may be held up a bit by the politics. Maybe provision can provide an alter provision for the people whilst all that's going on, while they decide what the political direction is. So it's very erudite, sensible comment that, you know, recognising how politics does have a bearing on health and what happens.
Fabulous. Okay, thank you. We're at the end now. Norm, I'll just flag my screen up so you can just see some of the comments that have come through for the local decision makers. So the increasing funding, formalising a principal offer to NHSE to give us permission to have this as a core principle, brilliant. Standardisation of records, absolutely, that kind of how we have that digital interaction between our data is really important for that joined up planning. Considering the things that we want to measure are not that, consider that the things that we measure are not what our population value, really, really important thing. So again, thinking about how do we use kind of our wider partners to really understand what our population's value from the services we offer. And then, you know, there's a plea here for just some more information needed on what those local services look like so you can engage more effectively. And that came up in my group as well. Because there are so few of us, and because I'm just mindful of time, I'm thinking instead of going to the next one, which is all about your feedback and future discussions, if we could just have just a general discussion very briefly around what you found invaluable about today's session. If you've been to any of the other sessions as well, a bit of a reflection on that, and what you'd want if we did something like this again. Would you want something like this? Would you prefer it face to face? Is the digital side quite helpful? What would be helpful? So just any feedback given. I'm going to my group will know I do this. I might just start picking on people if people don't respond. So don't suddenly go. Oh, brilliant, Anna.
I think that the digital sort of with its own, you know, caveat of Microsoft Office can a lot of people at this very quickly sort of time, but I think that the use of the digital vehicle has helped get people to the sessions. I think I remember myself and Andy being the only people in one meeting before all of the options were available. So I do think that that's really helpful. I also think that it would be really useful to know how to share these sort of videos with some of, you know, I certainly know that there's probably 3 people that I want to share the housing video specifically with, because I know that they're actively working on it. So knowing how to do that without having the SharePoint issue would be helpful. Just from a dissemination point of view, please.
No, that's great. And we've got a way of getting, we've got to set up a YouTube channel. So we've got a way of recording all of these sessions are on the YouTube channel. So we'll get this one up. I'm going to do that with the Emerging Leaders YouTube channel as well. So yes, we'll send the link out and it can be shared with whoever's interested. So that's great. And the digital side, we do like the networking bit that a face-to-face can offer, but we recognise the pressures everyone's under as well. So it's really good feedback for that. Thank you. Thanks, Anna. Anything else anybody wants to share? Laura? Anything?
I was going to say, is there other plans for the next sessions? Because I know we've had some really useful things on housing and drug use, but from my point of view, I wonder if there's anything about non-English speaking or people coming over for asylum seekers, that sort of core group of people that we provide care for, and it can be challenging. It's just if there's any input from that sort of sector planned, that would be useful.
Thank you. No, that's really helpful. So we don't have any of these Northwest sessions planned, but are you on the Emerging Frontline Clinical and Care Leaders course? Yeah, so we do have development sessions, so we can think about how we plan some of those into that. But we will absolutely feed that back into the ICB as well if they want us to, because we don't want us to keep doing this if the ICBs aren't kind of bought into it. So yeah, but perfect. Thank you.
Okay, thanks.
Charlotte, is anything from your perspective?
I don't think there is really. I think it's hard, isn't it, when you're on Teams and you're doing it from work, not getting distracted, and not having someone come and ask you a million questions. But at the same time, Teams enables you to get there in the first place, doesn't it? So there's got to be a balance. I think for me, these sessions have been really useful, feeling a little bit like we're all trying to do a lot of things and we're not quite sure if we're going in the right direction. It is useful to be able to listen to other stories and have different perspectives. They often these sessions make me realise I'm doing some of that already. But we're perhaps not shouting about some of it, you know, and it's about how we, I suppose, share what we're doing as well. So it's great.
So an opportunity to share some of the best practice as well from your own perspectives, because that will help validate and kind of like empower. Yeah, perfect. Thank you. Thanks so much. I've got a Karuna Ramneet whose camera's off and microphone off. Are you with us? Or
are you there, Ramneet?
I am indeed.
Oh, lovely. Welcome, Ramneet. Any final reflections? Because obviously we're a small group, so unfortunately you get picked on. So it's just to kind of get some feedback.
No, I think really interesting and useful session, you know, learning about the other side, and you know, it's really nice to have the perspective and the challenges everybody faced and how people are working together to make it a little bit better in their own way.
Right. And in terms of kind of doing more of these sessions, would you want us to help convene some of these in the future, either within your ICB footprint or Northwest or national? What would make sense for you moving forward? I mean, it's open to anyone really, not just from needs.
I mean, I think one of the things which is kind of a barrier to us attending the sessions is the notice. And, you know, for all our commitments, we need an 8 weeks notice minimum to make commitments if we can. So I think some of the meetings which have come across in the sessions, they have come with very short notice, which we end up declining. So I think that's kind of the one thing I would say that is minimum 2 months notice, and ideally, you know, longer than that to be able to see if we can actually engage.
No, that's really powerful, because we've always got the principle of 6 weeks, but I think if 8 weeks is what we need to do, we need to think about how we schedule these a lot more in advance. So that's really, really useful feedback. Thank you for that.
Yeah, really helpful.
From a practical point of view, I agree in the getting the notice, but also if you want to get people's diaries, it's going to be send the invite as a hold the date rather than as an email hold the date, because I had to put it into my diary manually to keep that slot sort of available. But if people don't do that, then you will probably end up having a clash quite quickly. So just from a practical point of view, but I think Dawn, you gave us quite a lot of notice, to be fair. So thank you for that.
That's really helpful, because I think with these sessions, because we use Eventbrite, there's an opportunity to download it, but not everyone does that. So I think having that automatic, I think it's just trying to keep on. We've got to figure out a way of how we keep on top of that and doing that, so it gets held in the diary. So thank you, really helpful feedback. Okie dokie. We are a CLN that's always wanting to give, and we want to give you 24 minutes back of your day. So Andy, I'll just hand over to you for a final thank you, and from my bottom of my heart, thank you so much for all the engagement and feedback you've been given. It's been amazing. Andy?
There's just a few of us here, but thank you to you and to everybody else who's been involved with these 3 particular sessions, and anything else that you're obviously doing in and around the CLN through courses or local work. We have got bits of work that we've been asked to do in various places, and footprints and PCNs, which of course we'll capture and try and, assuming they don't mind, make it transparent and useful, and producing a series of videos and libraries and things and making them available on YouTube, which is also useful. We are looking at supporting the system. We are asking the system to know what it wants, obviously, because we can only give what it wants, not obviously, well, we're not in a position to have authority to tell people what to do, not that they'd even think about that. So we will do our best to do that. We've had a lot of interest in a lot of areas, and at the moment we're producing strategies for comms and for 23 to 25 about how we maximize our presence to help people, because we're here for the greater good, like Susie says. That's what we're for. But getting your feedback is essential to making that happen, and then we can talk to various people about that to see if we can make it occur, whilst keeping you lot in the loop as well, so that you're fully aware of where we all are up to. So it's really just a big thank you, and that we will do our best to take your comments and deliver forward the kind of things that you're looking for.
Thank you, Andy. Okay, thank you everyone. Have a fabulous rest of the week, and hopefully we'll see you all really soon.